Well, good morning, everybody. My name's Sue Farrington, and I'm the chair of the Patient Information Forum. I was going to say a very warm welcome, warm, I think, in more ways than one. And I'm sure that you've now come in here, you're really relieved to see that there's fantastic air conditioning working. And I hope that the conversations that we have today will generate some lively heat and debate. This is PiF's 10th anniversary conference, and I hope you'll have noticed that we've really kind of shaped the programme in a very, very different way. It was based on your feedback, both after the last conference and through a number of surveys that we've been doing this year. And you said that what you wanted was something that was far more interactive, something that really addressed some of the real live issues that you were having to deal with in your workplace, and that you could then share that knowledge and understanding with your peers and maybe get some real practical solutions to take back to your workplace. So I hope we've structured the programme in such a way that it will give you lots of opportunities to ask questions, get answers, share your own knowledge as well, because that's invaluable. You will have ways of approaching things that other people may not have even considered. So this is going to be hopefully truly participative. And if we don't get things right, then I'm sure you will let us know, but we do welcome that feedback. It's really important that we look to see how we can improve year on year. Conferences wouldn't be possible, of course, without sponsors, and we've had a number of sponsors this year, and I'll be mentioning them throughout the day. But today, just at the top of the programme, I'd really like to say a particular thank you to our lead sponsor from Northumberland, Tyne and Wear NHS Foundation Trust, and our associate sponsor, NHS England, the Information Standard. So just very quickly, because you've got your programmes, what have we got in store for you today? We've got two keynote conversations. One is looking at empowering patients' engagement and involvement. And the second is we're going to explore championing how we can champion health information better and value professionals who work in the sector. You may have noticed at the front we have a piece of artwork which is going to be evolving throughout the day. And I'd just like to introduce Debbie from Engage Visually, who's going to be capturing the ideas, the issues that come out of our conversations and other conversations that you're having, so that we've got a visual record to complement the conference record. So thank you very much to Debbie for doing that. And I think you're also going to be doing something in the interactive shared zones as well. Yeah, great. We've already had a lot of questions for the two conversations, but if anybody hasn't written a question down, or if throughout the process of our discussion you've got a burning issue you'd like to raise, you can either raise your hand or you can tweet us at hashtag PiFConf2015 or text Nicole, and all those details are in your programme. So after the two keynote conversations, there'll be lunch. And I really would say, please do go and have a look at the posters. We've had 19 posters this year and a really good array of subjects and conversations that are being explored. We've put in your pack a voting slip. So if you could vote, cast your vote for which you think is the best poster. And the winner will have a £100 Amazon gift voucher to spend, hopefully, on maybe developing their idea or taking their work forward. So it's really important that you contribute to that, and we'll be awarding that at the end of the day. So at least we will know that we'll have the poster participants here until the bitter end. And then after lunch, we will go into the interactive shared learning zones, and that's very much about based on the open space style. So it's very much for you to determine what is discussed in those zones, what are the subjects. There is no predetermined or pre-prepared PowerPoint presentation. It's for you to really shape that interaction and engagement. And I'm sure, noting from some of the feedback we've had in the surveys, you've all got kind of burning issues that you want to seek answers for. I think at this point I would just like to say a very, very big thank you to people who have contributed to the surveys that PiF has put out over the last couple of months. And these are really playing an invaluable part in helping PiF to shape a new strategy. PiF is quite small, although perfectly formed, but we really need to be focusing down on what are the key things that our members want us to address. And we will be sharing the strategy over the coming months with a final presentation at our AGM in September. But there are a few key themes which keep on emerging, and they are quality, integration, and expertise. So what you're saying to us is that you really want us to continue a focus on quality and quality standards, and making sure that we support as wide a range of providers as possible to meet some of those quality standards. The second is about integration and really ensuring that information and support become embedded and are an integrated part of the care pathway. And the final area is about expertise, about your expertise, having that recognised, but also an element of continuous professional development so that you can up your skills. So there's an element of wanting to move more from the informal to have your area of work not professionalised, but really, really, truly recognised. Housekeeping, nearly forgot that. Now, I'm not aware that there are any planned fire drills. So if there are, I think the staff here will, if it's this morning, they will come here and make sure that we are all shepherded out to the right exit. Second thing is, if you have got a mobile phone, and I've just done it myself because I'm always the person who gets caught out, please could you turn your mobile phones to silent, not off, because we do want you to tweet. Okay, on to the main event, on to the first keynote conversation, which is empowering patients through engagement and involvement. Now, when the team were talking about having a different approach to our conference, they said, why don't we try and have a kind of question time debate? Well, I am no David Dimbleby, but I am really pleased to say that the calibre of our panel and speakers is one that question time would die for. So please welcome to the stage Professor David Haslam, Chair of NICE, Ailsa Bosworth, Founder and Chief Executive of the National Rheumatoid Arthritis Society, Dr. James Munro, Chief Exec of Patient Opinion and Patient, he notes, Paul Farmer, Chief Exec of Mind, and Jamie Root from IBM UK. So I think I can probably say that many of us have probably been encouraged by the 5-year forward view when Simon Stevens recognises the empowerment of patients as one of the key ways in which the NHS could meet the needs of a changing population. So are we looking at a future NHS where people are proactive partners in their own care, who are able to make informed decisions about what their care should look like? And I wondered if any of the panel members had any initial thoughts about this vision and how close we maybe are to realising the empowerment of patients. Maybe, David, if I could start with you, just for a very quick thought.
Well, your question was, is it going to happen? Should it happen? And the answer is not only do I believe it will happen, but I believe it's absolutely essential. I think probably for all the best reasons the NHS since 1948 has developed to be a very, when it's working well, very caring organisation, but within that care it's quite paternalistic and it sort of tends to keep information and so on to itself. And I think the only real way forward, I mean, I've felt this for my entire professional lifetime. Whose illness is it anyway? Whose problem is it anyway? You know, it's critical that that members of the public, patients, service users and so on are absolutely, totally involved in their care to the extent that they wish and feel is helpful for themselves.
James, from your perspective, you will see a lot of engagement through patient opinion, but what are they saying? Do they feel that they are being encouraged and empowered, or are we not there yet?
We're not there yet. For people who may not be aware, Patient Opinion is a feedback website. It's public and online, and you can read stories from patients every day, telling everybody, telling you what their care was like. And there's about 100,000 stories on the site now. And I think that people's experiences of care doesn't often bear very much relationship to national policy pronouncements. And people's experiences vary widely from place to place. Half of the feedback we get is very positive. And the things that people value in particular are being treated with respect, being listened to, and being given the information they need to know what to do next. Those are, it isn't rocket science mostly. It's simple stuff, and it isn't costly stuff. But in some places, those things simply don't happen. People feel that they're not happening. And I think that depends on the culture of organisations to some degree, which may be changed by national policy. But it also depends very much on the microcultures of teams and departments and wards within care settings. And they can vary quite markedly, even within an organisation.
And I wondered if any of the other panellists wanted to kind of have a quick comment before we go to the audience. Ailsa.
A little bit closer. I very much agree with what James has just said. I think there's a lot of rhetoric that's still out there. We hear these words, patient-centred care and shared decision-making and nothing about me without me and so on, repeated endlessly. But I think there are relatively few places in the UK where this is genuinely happening and patients are really being involved in their care and empowered in the way that is talked about. So I think we've got a long way to go. But as David said, is it essential? Absolutely. We're not going to get patients with long-term conditions self-managing effectively unless we all put a hell of a lot more effort into working on these concepts and strategies at every level.
Paul.
And I think just to add to that very briefly, my sense is what's different about the 5-year forward view from what we've seen from previous kind of policy pronouncements around this area. And I think that to me what's different about the 5-year forward view is that empowerment and ownership of individuals' health is now a must-do, a must-have for the health service to be sustainable in the long term. Everybody will be very familiar with the kind of the maths around this, the 8 billion extra funding given, but the 22 billion savings that are required from the NHS to achieve the kind of consistent level of service that's required. That can't be achieved unless you involve patients and individuals much more integrated way in taking ownership and taking responsibility for their own care.
Jamie?
In my role for IBM, I get to sort of compare what happens in healthcare and our experience in other industries. And many of our private sector clients spend enormous amounts of money designing journeys for their consumers and their customers, which can be a very good thing so long as it's oriented around an objective that is their clients or their customers. Those are the organisations that succeed. Those that optimise what they're doing around their own objectives and their own systems, tend to be less successful. And I think there's a parallel here. I think we need to move beyond this notion of admitting the patient in to what the health system is doing for them and orienting the health system around the goals that are absolutely personally the patient's and making ourselves subservient to that.
Thank you. I think that's a very good kind of introduction to this topic. We've got a question in from Una Quinn, who's from Healthwatch Lincolnshire. Una, can you raise your hand so that we can get a mic to you? No. Sorry.
Hello?
Yes. Great.
Okay. What we'd like to know in Lincolnshire, for those of you that aren't aware of where we are a very rural county, and what I've been asked by my CEO to ask is we would like the opportunity to raise the level of health inequalities within Lincolnshire, because this, compared to our neighbouring counties, it is all well and good having information and sharing it. However, if the information isn't used effectively and doesn't influence change, it would seem a futile exercise. For us in Lincolnshire, this is particularly true for many support services, not least neurology.
So is there a member of the panel who would like to have a first go at answering that question? David?
I noticed the way they all turned in my direction. So, I spent a lifetime as a GP. I can read body language. And I spent a lifetime as a GP in rural Cambridgeshire, next door to Lincolnshire, so I understand some of the issues. And certainly the whole issue of health inequalities, what was termed many years ago the inverse care law, where those who need the most get the least in healthcare, on the whole, the more affluent the area, the higher the quality of care and the less the need for high quality care in the area, and so on. So it's been a real issue for many, many years. Part of the reason NICE was set up in 1999 was to try and address the issue of inequality across the system. Particularly in relation to the drugs and so on that were available and could be used so that you would have the same drugs in Boston as you would in Penrith or whatever. But also gradually to develop more and more clinical guidelines to describe what good looks like as a national expectation. Now, the very fact that you're asking the question says that there is still this variability. And I think there are a number of potential answers to this as we go on. One is the NICE and the Care Quality Commission working together. So NICE determines what quality looks like, and CQC inspects against that to determine has quality been delivered to the expected standards. And that's number one. And the other really important bit is patient empowerment, is empowering people to know what good looks like and to then be in a position to challenge. And I know this is difficult, but I remember very well one of my own patients coming in to see me and saying he'd been reading the NICE guidelines and he thought I'd got him on the wrong drug. And I thought, my initial reaction was great, good. Not that I got it wrong, but that he was A, interested, and B, challenging. And that, for me, information is a real good in its own right in terms of education, but it's incredibly important in terms of empowerment. So both on an individual level and also on a health charity level, so organisations representing people with given conditions, they're in a position to know what good looks like and what they can and should expect. But I take your point, there's a way still to go.
Ailsa?
In our field of rheumatoid arthritis, we've made it our business as a national charity representing all the nations in the UK to be involved absolutely at the heart of the NICE technology appraisal process, to be involved with the NICE guidelines and with our professional societies guidelines, because I feel absolutely what David has just said. You need to know what good looks like. And as an organisation, that's what we spend a lot of time doing. So with every piece of information that goes out to somebody who contacts our society, we put in 10 essential things you need to know about rheumatoid arthritis that are encouraging people to understand key things they need to be asking and challenging and making sure they get as part of their treatment pathway. And I think that that's important for all charities to really actively engage in setting the national bench line for what good looks like and what quality care looks like. Because if you're representing a group of people with a given condition, if you're not involved in that process, then I believe you're effectively evading part of what I believe is your responsibility.
If any of you watch QI, you'll know that from time to time people say something, make a statement to the blindingly obvious, and an enormous horn kind of sounds out. So I feel an enormous horn about to emerge as I make a statement to the blindingly obvious, which is the difference between information and data. And I wonder whether one of the points that the questioner is making is about a sense that, and particularly thinking about the work that you're doing in Health Watches, which I think is a really interesting and emerging force for shifting experience, is this sense that there is an increasing amount of data being made available about both, whether it's from organisations like Patient Opinion, or whether it's about much more transparency about prescribing activity or outcomes, but a sense that that data isn't yet being utilised to the best possible, in the best possible way. And it's that bringing together of information and data that I think is really important and really powerful. So it's so important that people are empowered with the knowledge about and the information about the best possible treatment. But to some extent, I think the empowerment also applies to understanding what is the current state of play in a particular locality. So if in Lincolnshire, prescribing levels of a particular drug, or access to, let's say, in the world of mental health, access to a talking therapy is not at the level that it really should be, then that is another vehicle for empowering both individual patients but also communities to start to shift the agenda. And I'm not quite sure that we've yet, I think, collectively come to terms with this use of data. So on the one extreme, we've got data being used, I think, slightly to bash people over the heads with for poor performance, which is understandable, but is a slightly kind of blunt instrument. But on the other hand, I'm not sure we're yet, as a community, properly using that data that's becoming increasingly transparent to really drive change in our localities. And I think that's I think it's a particularly exciting dimension to what can happen in the future.
And I'm just wondering then if, from your background at IBM, have you got any thoughts on the whole area of data-driven information and how the insight can be used?
Yeah, sure. I'd like to pick up on what Paul was saying, because for me, I think, again, the thing that may unlock this more effectively is when we're able to put side by side data about inputs, access and services available and so on, and data about outcomes. And I think we have a health system that's very good at measuring activity and inputs and availability of services, and we will be able to drive improvement much more effectively if we are able to get as rigorous and rich data about outcomes. I don't want this to sound negative, because it's not a shortcoming of the NHS. I don't think anyone else anywhere else is necessarily doing it any better. But nevertheless, that's the opportunity that we have.
Thank you. There's a really good question, I think, that will follow on from that, and that's from Sandy Forsyth, who's the, if you can be showing your hand, the information manager from Target Ovarian Cancer.
Hi. How do we empower users to act on the information that they're given?
So very good. We talk about empowered patients, but actually, how do we go about doing that? James, I wondered if you could kick that conversation off.
Yes, okay, good, all right. It's an interesting question, isn't it? How do we empower users? I think there's to act on the information that we've given them. I mean, to me, there's quite a lot wrapped up in the question, and maybe some assumptions to unpick. There's almost a sense that when you give somebody some information, there's something that you think they should do, and they're not doing it. And that might not be empowering them. That might be trying to find ways to get them to do what you want. I think certainly from our perspective of patient opinion, the stories we hear from people all the time, people often don't get the information they need. But when they do, that information is delivered in a particular context, in a particular culture. And I think sometimes, supposing your GP gives you a leaflet, are they saying to you, go away and read this leaflet and don't bother me again? Or are they saying to you, go away and read this leaflet and come back to me with your questions and your thoughts about what you'd like to do next? I mean, there's a cultural context here that the information is being delivered or shared in. And I think it's that broader context that often determines what people will then do. I think in terms, I'm always slightly anxious about the empowering word. It feels like something that you do to somebody, and the person should be jolly grateful that they're empowered at the end of it. I tend to think of power a bit differently as something that people, it's a relationship really in which some people hang on to power and other people try and get a bit more power than they had before. And although health professionals often say they want to empower people, they certainly often don't act like that.
David, I could see you.
It's really, really good question. Great answer as well. Within NICE, we've been trying to look at this a lot, and next week I think we're running a second workshop on the whole issue of shared decision making, because one of the problems, I mean, even the fact that we're running a workshop after we've existed for 15 years on shared decision making tells you something, doesn't it? That an awful lot of the organisation of healthcare in this country has been based around single conditions with clearly defined outcomes and what good looks like and so on and so on. And actually the reality is that, first of all, because of so many people having multiple health problems, there are more people in this country with 2 or more long-term conditions than there are with 1 long-term condition. So multimorbidity is the norm rather than the abnormal. So in those sort of situations, who can determine what good looks like? Well, only one person can determine it, and that's the patient. So if you're someone, not with ovarian cancer, but with, let's say, coronary artery disease and hypertension and hyperlipidemia and chronic kidney disease and diabetes and what else might you have, osteoarthritis and depression, and that's a common collection, what does good look like? What are you trying to achieve? Well, the only way you can find out is by talking to the patient. So shared decision making about what you're aiming for is critical with multiple conditions, but also with single conditions. There's a very interesting guy called Al Mully from Dartmouth University in the States who's done a lot of work around the way that doctors and nurses tend to reach the wrong assumption about what it is their patient wants from care. And indeed we find this in NICE as well. When patients get involved in all our work, the feedback is frequently that what the doctors think good looks like doesn't necessarily equate to what the patients look like. So it's a huge process, but I really think because of the changing pattern of illness, it's just forcing more and more people in the health service to recognize you cannot treat everything as if you've got rheumatoid arthritis, you do this to people. You can only do it with people.
Thank you. I'm keen to get as many questions to you as possible. So is there anybody in the audience who's not submitted a question, who now, having heard the conversation, has got something you'd really like to ask? Yeah, no, Nicole's coming to you.
Thank you. I'm Theo Rayner from the University of Leeds and Luto Research. James, I think you absolutely hit the nail on the head. There's a phrase that I love, which is an empowered patient is not necessarily an obedient patient. And I think it's sort of an elephant in the room, really. We've got to accept that if we are empowering patients, engaging them and informing them, then they might not make the decision that we would like them to take. And I'm not sure health professionals have really bought into that yet. There's a great Australian study looking at bowel cancer screening where they used best practice to improve the information people got about whether they should take part in bowel cancer screening. And the result was that less people took part. Now, as far as I'm concerned, that's a good decision because they were given good information and they made a decision based on what they wanted to do. So I think, James, you made a very important point. Thank you.
Anybody got a question? Gentleman over there.
Good morning. Wyndham Lewis from New Gen Knowledge Works. I was wondering what was more powerful in providing patient empowerment, the content that we provide or Google?
Who'd like to kick that one off? James.
Google. And how are we going to change NHS culture? What's going to be more powerful, Simon Stevens or Twitter? Twitter.
Jamie.
It's interesting to look at the way that Google operate. They're a provider of information, and obviously, every pixel on the Google homepage has earned its place. The choice of colour, everything has been tested. Now, it's easy for them because it's all digital, and you can easily divide up who sees which version and make the comparison. But that what they're able to do then is, I mean, that's almost a trite example, but they're able to close the loop and make it very tight in terms of how quickly they can get something new in front of their customers and see how people respond to it. And I think that's something that, you know, would be interesting to think about how that translates into an environment where we're used to testing in the form of, you know, double-blind, peer-reviewed studies by academics that take some time to you know, report back. Clearly, we will still need those things. But when we're talking about information and engagement of the patient, we need to measure whether or not the patient has been engaged by the information.
Thank you. Ailsa, then Paul.
One of the things that we use to provide information for patients is a platform called Health Unlocked, and I'm sure that there'll be many of you in the room who may have a Health Unlocked page. This is an area where people can go and find out about their condition. They can blog, they can ask questions, and we've found that in a relatively short number of years that our Health Unlocked forum has now got many thousands of members from many different countries around the world, not just in the UK. And we've noticed that our helpline calls have actually gone down in the last couple of years because as our Health Unlocked engagement goes up. And so peer support, I think, is increasingly becoming an incredibly important way in which patients can engage with each other and get support from each other. And sometimes getting that information from another patient who's got that lived experience can be of more value to that individual than information that comes directly from their health professional, because that other person understands what they're going through, understands the issues. However sympathetic a health professional might be, they don't live with the disease. And so I think we're going to see over coming years that this digital use of these types of platforms increase more and more.
Yeah, absolutely. I think the you know, the digital revolution is probably the strongest tool for creating a truly empowered and a much more equal set of relationships. Certainly in our work at Mind, our equivalent online platform, Ellie Friends, which started as a kind of what felt like a bit of a kind of toe in the water, nice idea, weren't really sure what was going to happen to it, now has 5 figures, tens of thousands of people regularly visiting an online peer support environment where they are empowered both by information, but actually more by each other. And I think it is that combination of the two that makes a big difference. And another example, the mental health selfies that we have started to produce, where people are articulating good quality information, but in a way that is entirely in their own language and rooted in their own experiences. So these are totally changing the landscape. And as it comes back to a point about transparency and indeed that point about people's ability sometimes to make their own choices and not necessarily the choices that we might make for ourselves. As that continues to be more transparent, then these platforms are going to change the culture quicker than anything else. I think the real challenge that poses for a system that is quite often waiting for the outcome of a long-term research project is whether the system has got the nimbleness of fleet of foot to be able to respond to what people are saying in an appropriately quick way without becoming too defensive. But I think this is definitely going to this is the kind of strongest tool in the armory for patient empowerment.
Thank you. We've got another question now from Nina Barnett, who's a consultant pharmacist, care of older people at Northwick Park Hospital, if I said that correctly. Nina, are you here? Can you... great.
Hello. So my question is about how we help clinicians who I feel really still vary a lot in their attitude and their response to patient empowerment. And I mean, I see that in my daily practice. So how do we help clinicians see the value of empowered patients? And I noted what you said about your response to someone coming and saying, I've read the NICE guidance. And I think your response is commendable, but probably still quite unusual. So I'd like some Thoughts, please.
A really good point, and I suspect there is huge variability. The thing I find when I talk to medical audiences, they get really quite, some of them, let me choose my words very carefully, some of them get quite uppity about the concept of, who do these people think they are challenging me? If you turn the question round to the experience that they have had with the NHS, or their mum has had, or someone in their family, or a friend, or the sort of nattering that goes on over dinner parties, when, where folks, get really irate that the doctor wouldn't listen, then you can suddenly see sometimes the light bulb lighting. Hang on, if I feel that about what's happening to my mum, maybe I need to treat other people's mum with the same response. So I agree. I think that personalisation makes a huge difference. It's a critical part of medical education as well. Really encouraging young doctors, and I spend quite a lot of time sort of giving talks and lectures just on this exact area about whose illness is it anyway. It's not the doctors to look after.
Any comments from the rest of the panel you want to add to that?
There was a thing called the National Programme for IT, you may remember, and what happened was a bunch of IT doctors diagnosed a condition that the NHS had of not having enough digitisation and prescribed a solution. And a great many clinicians will have lived through that experience of having stuff done to them that was evidence-based and based on sound reasoning, but they weren't engaged. And I think, these are illustrations of the power of stories to make it real and personal. And I think in IBM, that's something we use a lot in terms of asking our sellers and colleagues to tell tales of when they've really made an impact for our clients. And that technique, I think, is very powerful.
James.
Yeah, I suppose our answer to this at Patient Opinion is a bit like what you're saying, really, which is to share people's stories and share them very publicly and try and get them to the people who need to see them. There's about 4,000 health service staff now receiving stories from Patient Opinion in real time about their particular service or their area of interest or whatever it might be. And many, inevitably, those stories give the patient perception, whether that patient feels empowered or not empowered. What you're hearing is that person's experience of care at that time. Yesterday, last week in my service. And I think what we hope is, over time, that as more and more staff are receiving those stories and taking note of them, they will see things, as David's saying, from the perspective more of the patient. Incidentally, some of those stories do come from staff, as David said, who are being treated and who are seeing both good care, but very often seeing care that they know could be better, and reporting very strongly on the experience of what it's like receiving a service, sometimes a service that they've provided themselves without realising what it felt like as a patient, and then giving that feedback. And that can be very powerful for staff to see other staff giving that honest feedback about what it's like.
David?
Yeah, picking up on that, the thing that's fascinated me through most of my professional life, the British Medical Journal has published occasional columns by doctors called Personal View, in which typically this is the story of a doctor who's become ill. And they almost all read exactly the same way. I was fine, and then I got ill, and you know what? It's really frightening, and it hurts, and they do stuff to you, and I never knew. And there have been hundreds of these darn things, and where have these people been all their lives? That they don't recognise that it's frightening and it hurts. So this, how we can build more of that personal. When I was a medical student, I wrote to one of the journals and said I thought every doctor ought to have a barium enema just to know what it was like. People thought I was a bit odd, but I know what I meant. I meant it then, I mean it now. If you don't know what these experiences are like, you tend to sort of distance yourself from it. It is tricky, though, because to a certain extent, doctors mustn't be too sort of cuddly about this and avoid doing nasty things to people when nasty things need doing. But you do it with genuine consent and sharing and so on.
I share the sentiments that you're expressing, but I would be really careful where you say that. I can imagine a whole load of sixth formers who are considering a medical career, and you're suggesting they have experienced various treatments in hospital could well put them off. I said people could ask questions via Twitter, and I've now completely ignored that. I do apologise. So Claire tells me a question has come in via Twitter. So do you want to tell us what it is?
Yeah, we've had a couple, but one was quite interesting from Macmillan Glasgow Libraries about, sort of takes us back to the point we had at the start about health inequalities. And because obviously there's digital inclusion, we're talking about lots of information online, but thinking more widely about people who maybe don't find it so easy to access peer support online. Somebody asked about the role libraries could play in widening access to information. So I sort of throw that to the panel about libraries and other routes to beyond online to really widen access.
Paul is nodding vigorously. I think he's obviously...
Yeah, I think this is something that we thought about a lot because exactly just as everybody assumes that everybody's on Twitter, which of course in fact only I think 18% of the population are on Twitter or something like that, and most of them seem to live in metropolitan London or wherever it might be. So it's really important that if we're truly committed to the whole question of inequality, we need to think about opening up different channels of access, and it's something we've thought a lot about in terms of how you enable people who are digitally excluded or don't choose or want to access information through a digital means to be able to be equally empowered, to use the theme of today. And we've looked at this through two routes. One is when the kind of height of the recession, we made a very clear decision to invest as much as we could in frontline services so that people could access that information as much as possible. And we made our printed information freely available through two routes. One was our local Mind network, but secondly through our local shop network of 150 shops. And now if you walk into any Mind charity shop, not only can you buy excellent materials at very reasonable prices, but you can also access information, paper-based information, in every single shop. And as part of that, we've also trained volunteers. In fact, taking a model from the Macmillan work that they did with Boots staff, we've trained our volunteers to act as signposters to interpret, if you like, that information that's available. So I think this is a hugely important route, and I think there are other environments where that can be used, and certainly libraries are a powerful place to encourage that.
And any other thoughts from the panel, Ailsa?
Yes, we provide health information to health professionals free of charge. They can effectively join our organisation as a free member, and we go out of our way to try and provide very simple ways in which health professionals can signpost patients to us, who then can choose how they interact with us, whether they ring us or just go online, look at the website, or download information, or ask us to send hard copy information. But I think trying to empower the health professionals to give that information easily is important. So we've designed some nice little cardboard holders that can just sit on the nurse's desk with a little free phone helpline card in it. So all they've got to do is literally give the card to the patient. They haven't got to go searching for brochures or other types of more bulky information. It's made as simple as possible. And we're also we're putting a lot more stuff on our website in video format, so that people who don't want to read stuff or who have health literacy problems can just watch a short video to tell them about the disease or other information that's relevant. So I think trying to find different ways in which people can access your information in a way that suits them, at a time that suits them, is really important.
James?
I just wanted to relate this question back to something else I was talking about earlier, which was the Health Unlocked communities. Because, of course, I mean, quite often we do think about going online as about getting information, but it's also about being part of a community, being connected to similar people, people that you can share with, people who can support you. And it's very difficult for many people to do that without being online, whether because, for example, they're in an isolated location, they may be confined to the home, or indeed they may have a rare condition and there may be nobody for 100 miles with the similar condition that they can share with. And what's extraordinary about going online is that ability to connect. To me, it's way beyond the information that's available. It's about the people who are available. It's about the relationships that are available online. And we simply can't do that without going online. And so it seems to me that many libraries now, I'm not no expert on libraries, but it seems to me that many libraries see a big part of their role as helping people to go online when they can't do that at home or can't do that without assistance. And many libraries focus very strongly on it. And I do think that's right because of the things that you simply can't do if you're not online.
Sadly, we have run out of time for this first conversation, but I would really like to say a very big thank you to all of our panellists for entering into the spirit of not knowing what you were going to be asked and just, as somebody said to me earlier, winging it. Thank you to the audience for the questions that you sent through to us, and I look forward to the next conversation. But round of applause for our panellists.